Okay, so we're on to our final talk of the afternoon, and I'm very happy to introduce Dr. Christine Brenckmann. I think she's a familiar face to everybody, and likely you all know her as an advocate for women's health. She's very passionate about women's health issues, and hopefully one day all her hard work that's gone into the pregnancy center will come to fruition and be successful. Maybe 2025 will be the year, Christine, that will make that happen. But Dr. Brenckmann's going to chat with us about contraception and contraceptive updates. And I think, are you going to present down here? Or? Sure, there's one just over there. And she's got a show and tell table.
Hello. All right. Thanks, everybody. I've been teaching contraception to med students and residents for somewhere over 10 years now. And I often end up on a Friday afternoon when everybody's pretty done. So my contraception spiel is very open to questions, very dynamic. I have lots of show and tell stuff. So last talk of the day, please get up, walk around, come have a look at the samples here, ask questions as we go, yeah, I think I'm also recognize that I'm speaking to a room where there's a lot of knowledge already. So the other thing I've noticed is that every time I teach this, I learn something. So hopefully you guys have something to teach me today as well. First slide, please. So general thoughts, I think, include partners in the discussion. It's not just an individual's responsibility, it's a couple's responsibility. Don't make assumptions about somebody's risk of pregnancy. So instead of saying, what are you doing for contraception to a woman who may have a female partner, say, is there a risk of pregnancy? Or if you have a transgender patient, not making assumptions about sexual orientation. Also recognize that the most effective methods that we have, how do I work this? Green one, okay. Recognize that the most effective methods we have are those that require prescriptions and providers. And right now we have a lot of folks who do not have primary care providers, don't have access, and so think about how you as a provider can improve access to the best methods of contraception for your patients. The other bit is give the longest prescription possible. So sometimes I see prescriptions for birth control pills for a month, and then or 3 months or something like that. So give it for a year, give it for 2 years if the pharmacy can supply it. But when you give it for a month, 2 months, 3 months, then that's somebody who's at risk of pregnancy because, gosh, it's annoying to have to refill something every couple months. And if you are late, then you end up pregnant. All right, so first I think we're just going to talk about some of the options. So for a lot of these, it's nice to touch them and feel them. So we have lots of copper IUDs, and there's actually this new one that I just got in the mail. It looks a bit intimidating, and so if anybody wants to come up, you can have a look. But it's called Yane, and it's supposed to be a copper IUD that does not require a tenaculum or a sound, and it's got this little membrane inside. Pass that to you. It's got a membrane inside here, and you're supposed to put it up against the cervix, and then you inject the water and then push this, and it's supposed to just push the membrane with the IUD through the cervix, so you don't need a tenaculum. I have to say I'm a little wary of it. But it is marketed as, like on their webpage, they say it's disruptive technology, so you don't need a tenaculum or a sound. But personally, I feel a little bit skeptical using that one. So I would hope so. Yeah, I think the first thing when I opened the package, I thought, like, this looks like it's going into, like, I'm doing an IJ. Yeah, yeah. So this is a new one, just so you know it's around. So I think, oh, I have no idea. It's not covered at this point because it's new. But I think the main thing to know is that you can't just put copper IUD on a prescription and send someone to the pharmacy. Because there's so many different types of copper IUDs, and the patient might show up in your office with this one, because that's what the pharmacy has, and they're like, it's a 380 copper IUD, so here you go. Yeah, it's, I played around with it. The water goes into this membrane in here, so.
Okay, so then you push the end?
Here, I'll see if I can. Sure. So, okay, we'll hold the microphone in your mouth. Sure. Thank you, Holly. All right, so you push the fluid. You have to unlock this. You push the fluid, and then you have to lock this, and then this you push through, and there's this membrane that pops up, and it has the IUD in it. And it's supposed to just push itself through, and then, well, I think I pushed too hard too soon, but, and I've played around with it. But this is this membrane, so I'll pass that around, you can maybe feel the membrane.
So is the membrane like a lubricant, sort of, to get through the cervix?
It's meant to push through the cervix, but, I mean, if you have a really small os or a stenotic os, like that's, you're just gonna end up pushing the cervix backwards, so. Yeah, because the tenaculum you kind of need to be able to hold and stabilize. Yeah. And so otherwise there are lots of other copper IUDs. There are a couple here that so again, I used to just write copper IUD, or you write a specific copper IUD and the pharmacy sends you whatever they have in stock. And so I've learned that's not okay. But the problem with the 10 years is, I'm gonna pass this one around. The two that are licensed for 10 years have, thanks, an inserter tube that's like a drinking straw. And I call it a cheese grater, because if you ever try to put this through a cervix, it's like, so this is the two that are indicated for the 10-year, both have this type of inserter tube. And I wrote the companies, and I said, you have a terrible inserter tube. If you change your inserter tube, I will only prescribe your IUD. And both of them said, we're not able to change our inserter tube. Here's a free one. And I said, that's not really the point. You have a terrible tube. But, I mean, I assume that that's a financial consideration, because why would you have a good 10-year when you can have 2 5 years back to back in terms of the money that you would get? Yeah. So there are two that have that kind of inserter tube. So make sure you're not prescribing those ones. So yeah, I don't know what I'm supposed to say, but so I have. So there's this great copper IUD chart from MedSask, and they list all the different copper IUDs that are available. And I've put a star beside the ones that I like, and I have comments besides the ones that I don't like. So, yeah. So the ones that I have a star beside, I don't know, am I allowed to say which ones you can take a photo of it, how's that? So there are certain ones where the inserted tube I don't like, and most of them I don't like, and I have 3 that I'm okay with. Stars means I like them, yep. So the other ones, there are ones that look like this, so they have a nice firm tube, it's relatively narrow, and so I have less objection to these ones, but they are quite spinny. And so if you put them on a cervix, often they slide off to the side or they spin around, and so I don't like putting these ones as much either. That's right. I think my original one said crappy tube and spinny top, but I had to make it patient friendly. So I do put the name of the copper IUD that I like, if I am doing a copper IUD, and I put on there no substitutions. And despite doing that, I have had the wrong type of copper IUD come. And unfortunately, the patient showed up and was ready for her IUD insertion. And I said, I'm sorry, I cannot in good faith put this IUD into you. Can you please take it back and tell the pharmacy that you need the one that I prescribed to you? It was the cheese grater, and the patient, it was the worst possible situation that you could think of putting a cheese grater IUD into. So. One of them has a nice tube and the other one doesn't. That's right. So the ones that are 10-year have the terrible tubes. So as you can tell, there are lots of different copper ones. All of these are different, and I have them labeled here, so you're welcome to come play around. Yeah. Absolutely, yeah. No, they cover them. It's just that Mirena is so much more expensive. So Mirena is like 400, Kyleena was 300, copper IUDs were like 50 to 80. And so, that's right, yeah. So those are all the copper ones. And then this is a Mirena and a Kyleena. So Mirena is good for 8 years. So I think we get referrals to our clinic for replacements at 5 years. You don't need to refer them at 5 years. Wait for 8 years. Unless they're using, if they're using it for menorrhagia and it's just not working anymore, then we'll replace it, obviously. Or if you're using it for endometrial protection with menopausal hormonal therapy, then it's 5 years, although I've heard someone tell me that with informed choice, you could do 8 years maybe. Yeah.
In patients who are using it for contraception, and if they're amenorrheic for a while and get light periods, but then it starts to become heavier periods, or really irregular bleeding in the last couple, 4 years in.
Then just replace it.
You replace it, and it's
Oh,
more
yeah.
likely to work again if it did the first time?
Yeah.
Yeah, I've had that too.
All right, so those are the IUD options. Then we've got Kyleena's 5. Yeah. We've got, and then we have combined hormonal. So the copper IUDs, obviously just copper. Kyleena and Mirena have progesterone only, no estrogen. And then we've got the ring, the patch, and pills. And those are progesterone and estrogen. We also have progesterone-only pills. The patch comes in Christine Brenckmann skin color. It's unfortunate. It just comes in the one skin color. Yeah, so the patch you do once a week. And then you take it off, which, as you know, with nitro patches, don't just keep putting a new one on. So take it off, put on a new patch, and then you can have a week's break, but you don't have to. So you can do continuous use with the patch, the ring. That's a real one, just if anybody doesn't want estrogen on their hands. Holly, just so you know, it's a real one with estrogen, so. Yeah, smeared on. And then I think, so Nuvaring. And then I've got the barrier ones. And I think it's important to talk about it because, first of all, nothing makes you want an IUD like holding a sponge in your hand. But these are the ones that are low barrier, ironically, so barrier contraceptions, but low barrier. So you don't need a doctor, you don't need a nurse practitioner, you don't need a prescription. But this, you can buy London Drugs. So to be used with spermicide, better than chance. And I finally got a hold of some cervical caps, which aren't actually sold in Canada. Yeah. Sponge. I think it's meant to be like 6 hours, just like any other barrier, like 6 hours. You put it in before intercourse with spermicide, leave it in for 6 hours after, and you can take it out. Female condom, male condom. If you're old enough like me, you've fitted some diaphragms, so we have a diaphragm fitting kit. You can't actually prescribe them anymore, but if you have a patient who would like one, you can fit one. So we have the diaphragm fitting kits. And then you can order it from the company, and the company will ship to you as a physician, and then you can just charge the patient at cost. That is a one-size-fits-all diaphragm, which is also quite difficult to get. I got a bag of samples from a sex shop in Toronto. But, and those ones are the fitting ones. They have the hole. That's right. There is a role for barrier methods in terms of people who have contraindications to hormones, people who only need as needed contraception, people for whom, if they do get pregnant, it's not a big deal. But I think there is a lot of misinformation that they are really reliable. So I have some patients like, oh yeah, we'll use condoms. They're really good, aren't they? And I kind of go like, oh, they're actually more like 75, 80%. And they go, oh, really? Like, I thought they were like first line, like really good. Like, and so I think there is a role for education. And then Susie has our Nexplanon sample there. So Nexplanon is an implant, goes into the arm. So it just goes in the non-dominant arm, generally. And I think the nice thing about that is that you never have to guess which arm it's in, because then if the patient can't remember, you just say, are you left-handed or right-handed, and that's not going to change. So it'll be in the non-dominant arm. The one thing with the Nexplanon is that it's a really large bore needle. So for most people, but especially for those who are needle phobic, I make sure that if I'm walking towards them, I'm not walking towards them showing them the large bore needle, because it can look quite intimidating. I usually just try to keep it behind my back or out of sight. Yeah. But I think the nice role of the Nexplanon is that, so the overarching theme here is that of choice. There are lots of options, and our role is to know what the options are and tell the patient what their options are and what the pros and cons might be, and it's the patient's job to choose what's right for them. So one of the nice things about Nexplanon is that it's long-acting contraception. You can put it in literally anywhere. You could put it in on a street corner as long as you have some freezing and a little bit of cleaning. Width-wise, it's
basically a toothpick without pointed ends. It's just about 3-4 centimeters. Yeah, except for white.
yeah.
I just have one sitting in my office to show patients. Is that all it is?
Okay, so in terms of how do you choose? I think first of all, like your big questions are: do you want to get pregnant in the next year? Yes or no? Do you want to get pregnant in the next 10 years? Yes or no? And also, how important is it for you not to get pregnant? So if you're someone who has coagulation disorder, you need preconception counseling, you need to see MFM prior to conception, it's probably really important that you don't get pregnant, and relying on a sponge is not going to be your primary method. Okay. Then, yep.
There used to be phenomenal little books that were birth control pills with all the different kinds of estrogen and progesterone that helps you compare side effects if they still want to be on an oral contraceptive, but
RX files. Yeah.
still lets us do that, doesn't it? Make it, if it's too energetic, if it's too much
Yeah.
too much for that.
Totally. So my favorite resource for teaching residents, for talking to patients, is this lovely RX files chart. So this is the one that has all the different birth control pills.
Yeah, sometimes you want to go a little less estrogen or a little, they're bleeding or they're not bleeding.
Yeah.
Change the estrogen progesterone balance.
Yeah. So the nice thing about this chart is right at the bottom, it has symptoms of too much, too little estrogen, too much, too little progesterone. The interesting thing is that it has symptoms of too much androgen, but it doesn't have symptoms of too little androgen, which I think is a bit of a failing in how we talk about contraception, because I think it rests on the assumption that as women, we want less estrogen. And that's certainly true for hirsutism, for acne, stuff like that. But testosterone in women gives us libido, mood, energy, strength, all that kind of stuff. So there is a role for androgen, and I think that is one of the limitations of this chart. So once you've done your sort of initial counseling, and I often try to ask the patient, like, what do you know already? What is it that you're hoping for today? And some people know right off the bat what they want. Some people say, what do you recommend? You can try to sort out, do they need contraception only? Do they need help with menorrhagia? Do they need help with acne? All that kind of stuff. And so in terms of choice of estrogen, which is the slide I have up here, so there's a lovely app called the Medical Eligibility Criteria. It's free, put out by CDC, highly recommend it. It shows you all the contraindications for pretty much all the things you could think of. And so first of all, you need to think, is estrogen contraindicated? And if it is, then you need to go with the non-estrogen containing options. So IUDs, Mirena or Kylena, the implant injection, all the other things. If estrogen is not contraindicated, and there are lots of nice reasons why you do want estrogen, so right at the bottom stabilizes the endometrium, contributes to contraception, you avoid things like vaginal atrophy, and you also maintain bone mineral density. So then you go and think, well, what type of estrogen do I want? And most of them have ethinyl estradiol, so you're pretty limited in terms of your choices. But there is one called Nexstellis, and it's unfortunately not covered in BC, so you'd have to pay for it yourself, but it does have estetrol instead of ethinyl estradiol. So estetrol is thought to have less of an impact on breast and liver. I think it's being used a little bit more in perimenopausal folks. It's thought to have maybe less VTE cardiovascular impact, and it also doesn't bioaccumulate in the environment. Running out of breath. Yeah. Good question, I'm not sure. But I think, yeah, I don't know, actually. So anytime you give oral estrogen, but also transdermal or vaginal estrogen at contraceptive doses, it's different for menopausal hormone therapy is my understanding, but anytime you give estrogen at contraceptive doses, it's going to increase your sex hormone binding globulin, which is going to lower your testosterone. So that's going to help with acne, it'll help with hirsutism, all that, but can also affect, so it can give you sensitivity, so vulvodynia, can give you low libido, can give you all those things. So again, I think that's the failing of this chart, where if you have those symptoms, you maybe want something that's a little bit more androgenic. And I think I'm going to get to that in the next slide. So then we're talking about choice of progestin. And I think it's important to recognize we're not giving progesterone. We're not giving natural progesterone for contraception. We're giving progestins. And they all have a slightly different action than our natural progesterone. So there aren't as many, but there are some contraindications to progesterone. And again, you want to use that medical eligibility app. And of course, if you're looking for things without progesterone, mostly barrier methods, IUDs, and the other stuff. I'll talk about those ones later. So this is actually where you have the most ability to tweak. So you're looking at the type and the route of progesterone. Most of them are going to be oral transdermal options, and then we also have Mirena and Kyleena. So those are local, but a little bit systemic as well. So there are lots of different types of progestins. There are the original ones that were developed, like medroxyprogesterone acetate. So that's Depo, the injection. That's the one that I least like. So Depo is the only one of all these methods that will delay your return to fertility. Once it's in, if you don't like it, you're kind of hooped. Then we go on to the 19 nortestosterone derivatives. So the first generation, second, and third. I do want to point out for second generation, so levonorgestrel, those are somewhat androgenic. So if you're looking to increase androgenic effects, then you can prescribe one of those. And that's going to show up on this RX files table. Third generation one's a bit less androgenic. So that's etonogestrel, the implant in the ring, norelgestromin, which is the patch, desogestrel, which is in a bunch of combined pills, and norgestamine, which is also in the pills. Last but not least, some spironolactone derivatives. So these are actively anti-androgenic. So that's stuff like Yaz, Nextellus, Slind. They all have drospirenone in them. I think important to recognize that high doses of progesterone are going to suppress the ovaries, so that will also suppress estrogen and testosterone. So if you're looking to optimize androgens, like libido and energy, you could go with a Kyleena because it's a lower dose, and it has an androgenic progesterone, and it's mostly local with a little bit of systemic. Does that make sense? Then you're looking at choice of hormone regimens. So most of the pills are 21/7. Some of them are 24/4, so 24 days of active pills, 4 days of placebo. Lolo has 24 days of estrogen, progesterone, 2 days of estrogen, 2 days of nothing. And then lots of continuous options. So if I am prescribing the pill, which I actually do a couple times a year only, because I think most people in our practice have IUDs. But if you are prescribing a pill, I usually try to do a monophasic pill. So there's also a biphasic and triphasic where the level of hormone changes depending on the week of the pill pack. It's nice to have a monophasic because then you can do it continuously. So you throw out the placebo week and you just take it continuously. So you don't have to, but I think in practice, when I've had people do it, they can't go more than about 3 or 4 months without starting to spot. So the directions you can give people, and then they can create their own regimen, which works with their life, like med school exams, weddings, holidays, all that, is that you have to be on it for at least 21 days and off it for no more than 7. So you can have a 63-day on, 2-day off. You can have a 124-day on, 6-day off. And if you do start to get spotting, you just stop your pack, have a withdrawal bleed, no more than 7 days off, and then restart. We talked a little bit about choice of copper IUD. There are a couple on the market that have less copper than 380. The one that's internationally recognized is 380 of copper, not 300, not 200. So always go with the 380. In terms of coverage, fortunately our government is paying for contraceptives this year, and next year I hear menopausal hormone therapy. So there's full coverage of pretty much everything, partial for some of the name brand ones. There's no coverage in BC for any kind of patch because there's no generic, as well as Nextstellis, Slind, which is progesterone only, or Ella, which is an emergency contraception pill. Ring, so the generic is fully covered, and NuvaRing is partially covered. Analgesia for IUD insertions. So this is kind of a hot topic in social media at the moment. Roberto Leon, who used to be an OB guy in here, did a lovely series in This Changed My Practice, and he did a part 1 and a part 2. And he talks about 3 different types of analgesia. So the first one is CNS, and he talks really about how important it is to educate people about what the process will look like. So super important. You can do Ativan just prior to, and a lot of us are now using Penthrox, which is an inhaler, methylfluorine, which you can use in the office. Lasts about half an hour, a little bit of so it has some analgesic effect as well as anxiolytic. Also important, the day of, to have someone who's there holding your hand, talking to you, calming you down, super important. And then second level cervical, so doing a pair of cervical blocks. Some people use lidocaine spray. I've heard that stings, so I generally don't use that one. Does anybody here use the spray? And
About 10%. I warn everybody, but only about 10% mention it, and it's gone within 10 seconds.
yeah.
Usually.
And then for the uterine, so I usually get people to take at least 400 of ibuprofen. You could take 600 about an hour prior to insertion. And then obviously you can take ibuprofen, Tylenol throughout the day afterwards. Anyone have any? So I saw a study about instilling mepivacaine into the uterus. I've never done that. I don't know if anyone here has ever done that. I think it would numb the inside of the uterus, but I don't know that it would help with cramping. And then just some specific populations. So teens, there's a good guideline from Canadian Pediatric Society from a couple years ago. Teens should have at least 30 micrograms of estrogen if they're on a pill for maintaining bone density. Athletes, you want to optimize testosterone. So again, with the things that I talked about prior. Postpartum, it's fine to give progestin only, and it doesn't have an impact on lactogenesis. Generally, we try to avoid estrogen for the first 4 to 6 weeks. We can do post-placental IUDs and IUSs, or we wait until about 6 weeks postpartum. And that's because there's an increased risk of perforation in those first 6 weeks. And then for perimenopausal, again, sometimes we're also using hormones to help manage perimenopausal symptoms. We're also looking at a population that might have other comorbidities as they get older, more cardiovascular contraindications. All right, and that's it. Any questions?
So they have a period 4 weeks after their pregnancy, and you want to try, I thought you tried to time it with the period, but you say go to 6 weeks. And you don't have to worry
Yeah, because the risk of perforation is still high. Well, then you have other options. Yeah.
Just a comment about the athletic use for birth control pills and or contraception, and that it might be helpful for reducing their menses for athletic performance.
Yeah.
There's studies about ACL ligament injury for athletes during their menses, and reducing their menses and clocking their performance is something that's well studied in literature for athletic performance. And the second comment I had was Penthrox use for IUD insertion, and it's kind of interesting that in our offices we can have this, and I'm not sure if you have a nurse with you or if the patient's being monitored for their post-anesthetic exposure, but it's still, it's one of the kinds of anesthetic agents that can be at risk for malignant hyperthermia. So you need some training and an MH kit in your office.
Yep.
And the second thing is that there's protocols that are being bandied about for the college for who's acceptable for use for this in the office. And it seems kind of interesting to me that it's being well done for the offices, but it's kind of hard to get it in the procedures lanes in the hospital, like for ACU or for X-ray.
Interesting, yeah. It's also not indicated under 18, which is kind of the population you'd want it for. Yeah, Liam.
Do you have a different IUD for nullabs and multiples?
Personally, I don't.
Kalina Rep, Kalina Marino Rep came to our office maybe 2 years ago. She said that she uses Kalina for nullabs, Marina for multiples.
I think there are a couple millimeters difference in the size of the IUD, but in practice, I base it more on, like, you can use a shorter, like for the copper IUDs, there's lots of options. And you could use a shorter one for a nullab whose uterus hasn't been stretched, but I would generally go with all the other reasons for choosing between a Kylina and Mirena. Yeah.
And for the copper IUDs, which would you use specifically for nullabs?
Am I allowed to make recommendations or just choose? So a Liberté UT short I could use. Yeah. And Liberté UT also comes in a silver copper rather than rather than a nickel copper. So the other ones have nickel, and so if you have a nickel allergy, you can actually react to the IUD. Something you wouldn't necessarily think about.
I'm probably more thinking out loud with this, but anyone who works or has clinic near a facility or works in facility, like we're in Mackenzie, so the hospital's in the clinic kind of thing, for people who are really anxious, does anyone use like procedural sedation at all? I'm just thinking like in Emerge, I've used midazolam for less, like lancing abscesses and stuff, if the patient's very worked up over it. So I'm just curious. I've never used it for this really, but I've, the thoughts cross. Well, I've had two thoughts. The first is I'm less comfortable partially sedating someone for a sensitive exam, but I've often been doing it and they're, vagal or not comfortable or painful, and I think, would a bit of midaz be the worst thing here?
So I don't, but I believe the gynaes do in ambulatory care, and Dr. Odulio said they can get them in about a month. I don't know if that's still the case or if that's kind of all the time, but I don't know if any of the gynaes want to weigh in here.
So, Dick, you used to be a medical director, so would I get, if I did that myself, would I get a big slap on the wrist? Would that be allowed, do you think, in our settings in Mackenzie, if I gave some intranasal midaz or some IM midaz in a small dose? I mean, we've got the nurses there in the facility.
You use it for everything else.
Yeah.
The only thing, as long as you have a
Do they?
chaperone for the reason you said before.
Well, I'm just thinking,
Confidential.
sometimes the facilities get picky over elective versus emergent and stuff like that, but I mean, I couldn't imagine there being a risk to the patient.
I don't think
Hi, sorry, unrelated question. You mentioned bone health for adolescents and requiring 30 micrograms of estrogen. I've never heard that before, so it's good to know. So I guess when they hit 20 then, you would be able to like successfully switch them over to something else, like lower, potentially?
I don't know where the cutoff is, or if they're doing fine, just leave them.
Okay, fair. And then what about bone health for the progestins? Like I artificially have kind of like a year or 2 years where I'll put people on the depot injection for, but after that I get like a little bit nervous.
Yeah.
I don't know where that came from, but just sort of my
So
practice.
there is a known decrease in bone density with progestin, and you're supposed to tell people about it when they start it. They're supposed to take calcium and vitamin D while they're on the depot.
Is it just the depot though, or is it all the progestins?
So I was thinking about it. I don't know if anyone else in the room knows whether stuff like the Nexplanon would give you a decrease in bone density, because really it's a high dose progesterone and you'd expect the same kind of thing as depot. And the Mirena and Kylena, I don't think you'd have to worry about as much because you don't get as much ovarian suppression. It's more local, less systemic. And then the progesterone-only pills are generally like one of the reasons why they're like a mid-range dose. And so I think you get less ovarian suppression, which is why they're also less effective. I would have probably had the same concerns about something like Nexplanon, but I don't know if that's true. Yeah, it's not supposed to, but I don't know why. I don't know if that's just because it hasn't been studied. But we did have someone low bone mass, on depot, smoker with a fracture in her 30s, I think. So and low bone density. I think we ended up checking her bone density and it was low. But, chances are it was probably low already before we had her on the depot. So not a great choice for her, but that was her option. Like that was her informed choice consent.
Just another quick plug for eating disorders. If you have a adolescent who is amenorrheic because of an eating disorder, don't put them on a contraceptive for that reason. It's not bone protective. If they need contraception, for contraception, that's fine, but it actually makes it harder for us. We use return of period as a marker of return to a healthy weight, and so don't put them on it unless they also need it for something else.
Awesome. Comments or questions? Good. Done for the day.
Thanks, Christine. So that's the end of the 48th annual Northern Doctors Day. Please fill out your evals if you have comments on making it more of a theme, if you preferred that, if you didn't, if you have suggestions, if we were to do another theme for next year for number 49, please put those forward so that we can consider them as a committee. Jaylene, just let me know, everybody's CME certificates will be emailed out kind of mid-December, just because, I don't know, something technical with the numbers from UBC or the college for that. So expect that to come to you from there. Just a reminder, the banquet is tonight. So we're celebrating 3 retirees from the community of Prince George. We have a live band. There's some line dancing that I got talked into, and I got 2 new dances this year. So please come back. I know it's a bit of a snowstorm. I haven't actually looked outside, but it's a fun evening, and I hope to see most of you there. So have a good rest of your afternoon, and hope to see you this evening.